Welcome everyone. Today we will discuss about the second part of diabetic ketoacidosis. We will focus mainly on the management. So, what is the emergency management? At first, we have to manage airway, breathing, and circulation, the basic ABC. Intubate the patient if the GCS is less than 8 for breathing oxygenation as per requirement. You have to insert two large bore IV cannula and send the blood for blood glucose, electrolytes, urea, CRP, ABG, and ketone body, that is beta hydroxybutyrate, and give initial fluid boluses. In case of the patient is in shock, you can give 10 ml per kg bolus over 15 minutes. If the patient is not in shock, then give 10 ml per kg IVNS over 30 minutes. But you have to subtract this from total fluid. We'll discuss it later on. Now, if the patient to PICU if there is severe decay, age less than 5 years, new onset type 1 diabetes mellitus, hemodynamically unstable patient, and altered sensorium. Now, we are coming to the management proper. What fluid we have to give? We can give mainly NS. Okay, normal saline. So, how we will calculate the requirement? It is deficit plus maintenance. How we will calculate the fluid deficit? As per BISPET guidelines, I have already said what is mild decay, what is moderate decay, and what is severe decay. In case of mild decay, we have to consider fluid deficit as 5%. For moderate, it is also 5%, and in case of severe decay, it is 10%. Now, fluid bolus given for the initial phase for patient with shock, we should not subtract it from total fluid, but initial 10 ml per kg bolus will be subtracted from the fluid if the patient was not in shock. You know how to check for shock. Okay, now the deficit should be replaced over 48 hours as per this protocol. But there is another protocol known as Milwaukee protocol, which has been given in Nelson. It is different, but here we will discuss only on BISPED. Okay, now moving on to the next part. For the maintenance fluid, we will give maintenance fluid as per Holiday Segar formula. You know already. For the first 10 kg, we will give 100 ml per kg, then 50, then 20. Now, the calculation main part. Hourly rate will be deficit minus the initial bolus in case of non-shock patient divided by 48 hours and maintenance per hour. Okay. Here is an easy example. 10 kg weight, child has pH 7 with shock diagnosed with decay. So, pH is 7, so it is a case of severe decay. Now, as the pH is less than 7.1. Okay. Now, the initial bolus 10 ml into 10 kg equal to 100 ml over 15 minutes as the patient was in shock. So, if we use insulin at 0.1 unit per kg per hour, we can change the fluid to 10% dextrose containing fluid. Okay, like isolate P4. Now, potassium supplementation we should give when hypokalemia occurs in decay due to secondary hyperaldosteronism due to RAS system activation. As there is dehydration, there will be less renal blood flow, so RAS will be activated due to vomiting, due to osmotic diuresis by hyperglycemia, cellular potassium loss due to the hydrogen ion moving into the cell and the potassium ions are coming out of the cell, and insulin therapy. So, add 40 millimole per liter KCl to the ongoing IV fluid unless there is evidence of renal failure 1 hour before initiation of insulin therapy. Okay. Now, practically speaking, we can add potassium if the patient has passed urine. We can give potassium supplementation. We usually put 1 vial of KCl in a bottle of NS. So in 511 NS, we can put 1 bottle of KCl. Okay. Now, if there is hypokalemia, temporarily stop insulin infusion as insulin can cause dangerous hypokalemia and made in central venous catheterization if potassium is more than 40 millimole per liter. Okay, if we are infusing potassium more than 40 millimole per liter. Now, insulin therapy. No insulin bolus should be given as it increases the risk of cerebral edema and hypokalemia. Once dehydration started, blood glucose tend to fall, so there will be decrease in serum osmolarity. So there is risk of cerebral edema if insulin started early. So we should use insulin 1 to 2 hours after beginning of IV fluid therapy. We will use regular insulin therapy at a dose of 0.05 to 0.1 unit per kg per hour. Now preparation. 1 ml of insulin contains 40 units of insulin. We will mix it with 39 ml of NS. So 40 units of insulin in 40 ml solution. So 1 unit per ml. Better to start with infusion at 0.05 unit per kg per hour. And 0.1 unit per kg per hour may be required in case of severe decay. Once blood glucose is less than 14 millimole per liter or 250 mg per liter, decreased infusion to 0.05 unit per kg per hour if started at 0.1. Now, if the blood glucose level less than 6 millimole per liter or 108 milligram per liter, then increase the glucose concentration of the IV fluid. If persisting ketosis, continue infusion to at the rate of 0.05 unit per kg per hour. If the blood glucose further falls to 72 mg per deciliter or 4 millimole per liter, IV bolus of 10D at 2 ml per kg and increase the glucose concentration of the fluid or in the infusion. Insulin therapy to be reduced for 1 hour. It is a common question that when we will convert the infusion of insulin to subcut insulin, the ketosis is resolved, that is beta-hydroxybutyrate less than 1 millimole per liter, pH is less than 7.3, bicarb more than 15, no anion gap, no MSS, no, the serum sodium will be within normal limit. How to switch? Now, start subcut insulin at least 30 minutes before stopping up insulin therapy as per BISPED protocol. That is two other methods mentioned in Nielsen 22nd edition. Basal insulin plus insulin lispro aspart or regular insulin. We can give basal insulin when stopping the insulin infusion. We can give it 15 to 30 minutes before stopping infusion. We can give insulin lispro or aspart, and regular insulin 1 to 2 hours prior to stoppage of insulin therapy. One dose of basal insulin at bedtime with insulin infusion still on. Stop infusion 12 hours later and make the switch. That is two methods. Total daily dose in new onset type 1 diabetes, if in case of prepubertal, that is 0.75 unit to 1 unit per kg per hour per day, and in case of pubertal, 1 to 1.2 unit per kg per day. 40% basal dose at night and 60% bolus dose 3 times before the meal, before breakfast, before lunch and before dinner. Now there is a very common query. Can we use bicarb to patient of decay? It is not usually done, but in case of when we will use bicarbonate therapy, in case of cardiac dysfunction due to blood pH less than 6.9 or life-threatening hyperkalemia. These are only two areas when we can use bicarbonate. Now, supplemental sodium in case of decay, or what is the status of sodium in case of decay? Serum sodium is normal to low due to osmolar dilution. How to check the corrected sodium? Measure sodium plus 1.6 into glucose in milligram per dl minus 100 divided by 100. So, serum sodium rises by 1.6 millimole per liter for every 100 milligram per liter reduction in blood glucose level. If corrected sodium rise is more than 150 millimole per liter, then suspect severe hypernatremic dehydration, reduce the fluid infusion rate, change the composition, okay, or change the composition. If carotid sodium falls despite treatment, excess pre-water accumulation and risk of febrile edema is present. Now, phosphate replacement, total body phosphate low in decay. If serum phosphate less than 1 mg per deciliter, then phosphate replacement needed. Now there is hyperchloremic metabolic acidosis in case of decay. Why it is occurred? Due to administration of large amount of chloride containing fluid like normal saline and KCl, there is preferential renal excretion of ketones instead of chloride. Okay, how to prevent it? You can use wrinkle lactate or replace KCl by potassium phosphate. Now, overall electrolyte status, there is hyponatremia, there is hypokalemia, there is hypophosphatemia, but there is hyperchloremia. Okay, now what is anion gap? Serum sodium minus serum chloride plus serum bicarbonate. Decay is a case of HAGMA or high anion gap metabolic acidosis. If anion gap more than 35, then consider lactic acidosis to be considered along with decay. Now, monitoring, we should monitor vitals, CBG, GCS, intake output insulin rate at admission, and then every 2 to 4 hourly serum electrolytes, ABG or VVG. Now, serum electrolytes, ABG and beta-hydroxybutyrate. If acidosis is not correcting, then IV cannula is not patent, insufficient insulin infusion, inadequate resuscitation, fluid calculation error, sepsis, hyperchloremic acidosis, salicylate or other drug poisoning should be considered. Now, what are the complications? Metabolic complication, overall it is most common: hypoglycemia, hypokalemia, hyperchloremic metabolic acidosis, and hypernatremia. Cerebral edema is the most dreadful complication, and it is the most common cause of death in case of decay infection like mucormycosis. Renal failure, intestinal necrosis, cerebral venous thrombosis, and DVT, rhabdomyolysis, arrhythmia, pulmonary edema, aspiration pneumonia, and pancreatitis may be the complication of it. Okay, now the most dreadful complication, cerebral edema. It can occur 4 to 12 hours after starting treatment. Now, what are the risk factors? Age less than 5 years, new onset type 1 DM, long duration of symptoms before treatment, and severe acidosis. And treatment related complication, use of sodium bicarbonate, use of bolus insulin, rapid fall in serum osmolarity, suboptimal increase in serum sodium, and overhydration in first 4 hours. Now, what is the mechanism behind it? At first, rapid fluid or insulin bolus, it will cause it rapid fall in serum osmolarity. There will be neuronal swelling and there will be cerebral edema. When to suspect it? New onset of headache with treatment, worsened headache with treatment, bradycardia plus hypertension with treatment, cranial nerve palsy like bilateral pupillary dilatation, fall in SpO2 level. There is a criteria known as Muir's criteria. It is not so much important, so I will not bother to it. Now, how to manage it? Now, head and elevation, maintenance fluid to be reduced by 1/3. It is often missed by us. Airway management should be done. Avoid hyperventilation. If PCO2 less than 22, you should consider intubation. We can use osmotic agents like 3% NaCl and mannitol. Not sure if it is decay or HHS. Decay or versus HHS. In case of HHS, there will be hypovolemia, there will be marked hyperglycemia. Blood glucose will be more than 600 mg per deciliter. There will be no significant hyperketonemia or acidosis, and the osmolarity will be more than 320 milliosmol per kg. It is more associated with type 2 DM. Now, how to manage it? Rapid fluid replacement needed. Initial bolus is 20 ml per kg instead of 10 ml per kg. Assume fluid deficit is 12 to 15%. Unlike decay, urinary loss replacement is recommended. Insulin therapy not needed. There is severe hypokalemia, so potassium must be included in all fluids. It is the guideline of BISPED. Now, thank you for your attention.